of you who haven't turned in your homework packet, make sure you do not leave without giving that to me tonight, please, or sending it to me in some fashion tonight. Stage 4, clot retraction. Actin and myosin, again, are going to be participating in this stage because they're going to be pulling on the torn, severed ends of the blood vessel and pulling it towards the center so it's easier for the fibroblasts to actually repair. And it's fibroblasts that do the repairs. Fibroblasts are kind of a jack of all trades. They can release factors, growth factors that help get all of the tunics starting to grow back to each other. And then the last step is fibrinolysis. And this might take a while for it to actually occur. It depends on how severe the wound was and how big the clot was. But fibrinolysis basically is if the wound is repaired, then you don't need the clot there anymore. And there is an enzyme that is going to chew it up. When my boys were younger, one of the cartoons we liked to watch and books we would like to read were these books called Little Miss Spider. And a lot of the books and cartoons that we would watch, Miss Spider would tell all of her children, which were also spiders, to clean up their webs. And the children would go out and just kind of slurp up their spider webs like it was spaghetti. And that's what makes me think when I think of plasmin. Plasmin is like the little spiders going out there and slurping up these fibrin threads and breaking them up. Plasmin is also found in your plasma, by the way, and it's found in an inactive form called plasminogen. And turns out thrombin, which helps make the clot, ends up activating plasminogen to plasmin, and there finally is our negative feedback mechanism where we're starting to put the damper on this whole process. Now, in clinical issues, when someone has a clot that is obstructing blood flow, say in a person with a clot in one of their brain cerebral arteries, and they're having a stroke, we can administer something to break up that clot. We usually say in a clinical setting that if we see a person that's having a stroke, we have what's called the golden hour, meaning an hour to figure out, is it a clot or is it a hemorrhage that's causing the stroke? Because stroke simply means that the downstream brain tissue is not getting blood flow. And it might not get blood flow because there's an obstruction, or we could have had an artery rupture, like from an aneurysm. So we have this golden hour to try and figure out which scenario it is, they say, because if we start administering something that will prevent clotting, we're going to make, if they're bleeding, we're going to make that worse. And studies have shown that the hour turns out is not so strict, that we might have up to 4 hours. We are doing blood work during this time. We are doing brain imaging at this time, trying to figure out what scenario we have. So you might read in textbooks this golden hour to figure things out. We have now bumped that to be a little bit longer, about 4 hours. Definitely in a clinical setting, though, when they're getting all of the results, people are running through the halls trying to get the doctor all of the brain imaging, the blood work, etc., so they can make the best call. If it is a clot, we can administer something called TPA. And a lot of times in a clinical setting, they call TPA the clot buster. No, it is not. Little Miss Spider is plasmin. That's what chews up the clot. TPA stands for tissue plasminogen activator. TPA will activate plasminogen into plasmin. TPA is expensive, especially when it's isolated from human recombinant cells or even from plasma that's donated. It's expensive. And we usually thread it through the vasculature, through a catheter, and we drip it onto the actual clot. It'll activate the surrounding plasminogen into plasmin. So we have found cheaper alternatives, and these cheaper alternatives work just as well. Urokinase and streptokinase. Urokinase is an enzyme that is found in your urine. And it too will activate plasminogen into plasmin. So that's a cheap source. And streptokinase is an enzyme that streptococcal bacteria will make, and that's cheap for us to grow and isolate from them. Studies have compared using urokinase, streptokinase together compared to using TPA, and they have similar outcomes. The issue that could be problematic is streptokinase coming from bacteria. It's going to have bacterial antigens and could lead to an immune response. But as far as effectiveness for activating plasminogen to plasmin, they have similar outcomes. And a lot of times the doctors are going to go with the cheaper alternatives. Are there any questions on that? Yes, Richard.
So thrombin activates fibrinogen and plasminogen.
Mm-hmm.
So building up the clot and breaking it down.
It's not breaking it down, but it's starting to activate the clot buster. Numbers will win. Numbers will win. As the platelets are becoming activated and leading to more activated clotting factors, the scale is tipping into their favor. But as the fibrin threads actually build, it traps the platelets and it creates like this barrier where platelets can't keep getting activated as much, and it also traps the thrombin. So containment starts to let plasminogen tip the scale in its favor.
So this all happens within how long?
Seconds to minutes. Mm-hmm. I do not ask you to tell me, is thrombin winning or plasmin winning? I ask you to tell me the steps. I ask you to tell me what could activate plasminogen into plasmin. I try and keep the line of questioning very clean for that very question you have. Because students say, which one's winning? It depends where we are in this process. Speaking of manipulating hemostasis, this is very important that you hear. If clotting times increase, I am not talking about a speed. It is not velocity. If I say clotting times increase, clotting times are that. Time, seconds, minutes. If clotting times increase, it means it's taking your patient longer to form a clot. If clotting times decrease, it means your patient is not taking as long to clot. It's important that you reinforce this is not a speed, it's time. We do manipulate hemostasis in our patient. I referred to heparin earlier. Heparin is endogenously found in your body. It is released by mast cells. And mast cells are part of your immune response. Heparin, when it's released, will increase clotting times. It will take longer to clot. Heparin binds to another plasma protein called antithrombin 3. And with their powers combined, when they interact, it is going to mean you're taking longer to clot. Antithrombin against thrombin. Thrombin is what leads to fibrin. So now we've got two bullies ganging up on thrombin. Clotting times will increase. Sometimes we want to reverse When we give heparin, an exogenous heparin, sometimes we want to reverse it and decrease clotting times back down toward normal. For example, the heparin that we put in that tubing that I told you about, glass tubing, even plastic tubing, when the surgery's over, we want our patient to start clotting. We need a way to undo heparin and antithrombin 3. Undo them. These two things still stay in your blood. It's just that the complex is removed. We're breaking it apart. But we're not removing these entities from your blood. We're removing the complex. They are no longer paired. We're giving them a divorce. And the way we can do that is through competitive binding. It's a lot like the OPG, OPGL scenario. Isn't that fun? So protamine is a substance found in fish sperm. How we discovered this, it's a party in my head. Did someone give too much heparin to a patient and said, "Get me something, anything," and someone randomly went to some cabinet and went, "Try this, sprinkle it on there. I don't know. Hey, it worked. What is that? Fish sperm." I don't know how. So many things in science are serendipity that we just, did someone happen to be walking through that just masturbated fish and tripped and I don't know. But these are the parties I have in my head. I'm sure there's a more boring story behind it. But the protamine will compete the heparin off of antithrombin 3. And when they are no longer together, they cannot suppress thrombin as well. There are different kinds of heparin, and this makes, so I want to tell you the truth, but then I'm going to tell you what I want you to give me on the test, okay? Well, this is very important for students. Low molecular weight heparin exists. There are some people with such a tendency to clot. Their clotting times are so short that they form clots when they shouldn't. We don't like to discharge patients on heparin because it is easy for them to over-administer, and then they swing hard the other way, and they won't be able to form clots well. There are some people that have such bad tendency to clot, however, that we might discharge them on low molecular weight heparin. That is the truth. And I'll give you an example of that, Antiphospholipid Syndrome, and I'll show you this picture. But for testing purposes, we will not entertain those extreme scenarios. Those are extreme scenarios. We do not like to discharge a patient home on heparin. If they were on heparin in the hospital and they need an anticoagulant therapy before we discharge them, we will transition them to a safer drug before we discharge them. And we will make sure that that drug is starting to work and increase their clotting times. And the drug I'm talking about is Coumadin/Coumadin/warfarin. Okay, so will you give me at all that we discharge a patient on heparin?
No.
But is there truth that some do?
Yes.
Okay. But for testing purposes, it's our standard. Heparin, hospital. Coumadin, when they can go home. Okay? There are other ways to manipulate clotting. So these are more simple. Perhaps you've gotten your blood drawn and you saw the different colored cap tubes, blues, purples. They have different anticoagulants in the tube. So purple tubes have different of these. Blue tubes, different of these. And when Farouk comes to draw my blood, he oftentimes threatens, let's just draw some tubes in the blue tube and just have your students freak out, because these anticoagulants work differently on calcium. They are all calcium chelators, but citrate is going to deionize the calcium. Oxalate is going to form a precipitate with the calcium. If the calcium is deionized, it will not be able to act as a cofactor. But this blood that's treated with citrate could go back into a patient. For example, when someone donates blood and the blood goes into those bags, we don't want clots to form. So those bags are treated with citrate. The blood can go back into a recipient. That's fine. But blood that's treated with oxalate forms a precipitate that should not go back into a patient that needs blood. Other tubes can be filled with EDTA and EGTA. Students oftentimes ask me, what do those letters stand for? Horrifically long names, chemical names with numbers in between the names. I mean, if you think pro-opiomelanocyte corticotropin is bad, these are horrifically long names.
Aren't they just like carbohydrate compounds at the bottom? To like feed off of, it helps store.
They sequester calcium. They grab it and don't let go. That's how EDTA, correct. That's how EDTA and EGTA work. They grab and hold on. Anyway, they grab. What was I going to say? Perhaps you've heard of O.J. Simpson and what he was accused of with Nicole Brown Simpson. One of the bits of evidence that was collected was blood at the scene. And what most people don't know is when you kill someone with a knife, many times you can hit bone and your hand will slide over the knife and you end up injuring yourself, which means your blood is now at the crime scene. So I'm telling you how to kill better. I will get fired before I retire. So whenever there is a stabbing victim, police kind of get excited because they know of this possibility, especially when the blood starts to spatter and the knife gets slippery, even more likely for them to cut themselves. So pick something else. Anyway. So the blood that was collected at the crime scene definitely started to show that whoever did this also got hurt in the scuffle. That's not hard to imagine because it was 2 against 1. And so it had to have been someone who was pretty strong to overcome 2 other individuals, 1 male, 1 female. And this person had to have been so strong that on Nicole Brown Simpson, they found a footprint, bruised footprint on her back, which suggested that whoever it was took her hair, put his or her foot on her back to arch her neck before slitting her ear to ear. It takes some brute strength to actually slit someone's throat. Most people get it wrong. Again, I'm going to help you kill better right now. And they just go here, which means you're cutting their windpipe, their trachea. The carotid and jugular vessels are way over here and pretty well protected by muscles of the neck, especially the sternocleidomastoid. So if you want to slit someone's throat, you pretty much have to go ear to ear, and chances are when you do that, you might hit the knife into the bone of the skull while doing that, and that invites the opportunity maybe to slip your hand and cut yourself. The defense team got this line of evidence thrown out because they said the samples were treated with EDTA and EGTA. That's how we preserve the samples. Binds to the calcium. Some enzymes need calcium to degrade a sample. So we don't want the sample to degrade before we can analyze it. The samples were treated with these chelators, EDTA and EGTA. And the defense team said, that's not proper. And everyone in the science community went, what? This is what we do. So they said it was improper specimen handling. And they were able to make that fly because they were able to show the jury that, no, this is not what we do. They should have used something else. That was part of their defense.
But that's not something that would happen nowadays.
I hope not.
Okay.
I hope not.
So you've heard one that had been used to store that.
I know. Sorry, this is going to sound awful. When you have a jury among your peers, it does not mean that they are Einsteins. In fact, you would prefer them not to be. Okay, now.
So the oxalate, like, what would be the situation where you would use that over the citrate?
Just if you don't need to put it back and you want long-term sampling of a patient's blood.
Okay, so it's more long-term than the citrate?
They're all pretty good. It's just citrate, you're using it because you are potentially putting it back into the patient. I forget, but I wish Kara was here. She would tell us right away which colored tubes are filled with what. So my purple tubes are EDTA.
Yeah, but how could they have done it?
And we can ask Kara, when does she use the oxalate tubes? Like, for what reason? If she were here, she'd be like, let me tell you. Because that's what she does all day. She's a phlebotomist. Yeah. Yeah.
So if someone was getting like a large amount of infusion, would you need to give them calcium as well because of the GI?
Because they still have calcium.
Okay.
Their blood
So they'd
still
be
has
fine.
plenty.
Okay.
Yep. No, I won't bother you with that story. I was going to give you a science fun fact, but in my head, like, most of you probably wouldn't enjoy the science story.
But it's fun.
It's okay. We'll move on. No. Here's more fun facts. Right here. Platelet facts. So, platelets, you heard me say, make thromboxane A2. And that means they have to have a COX enzyme so that the COX enzyme can take the arachidonic acid and morph it into that thromboxane A2 pathway. Aspirin, we have learned before, is an NSAID. But it is a NSAID that we need to be mindful of because when someone takes this aspirin, it goes and finds any COX enzyme and binds to it irreversibly, which means you would need to wait for more gene expression to make new fresh COX enzyme to get these pathways restored. This is particularly important if someone is on a baby aspirin long term before they have scheduled surgery. Ideally, we would tell them to stop taking their baby aspirin, and they're taking the baby aspirin as an antiplatelet. Maybe they've had some issues with clotting and the doctor says, take this as a precaution. If they're going to have surgery, we would want them to stop this about 10 days, 2 weeks before their scheduled surgery to allow for new platelet turnover where the platelets would have COX enzyme that is not impaired by the aspirin. The other NSAIDs are reversible. Tylenol, not an NSAID, and not having the same problem. It's reversible as well. Turn down my noise. Okay, so that's why it's important for us to wait before scheduling the surgery, if we can do it. Another issue with someone taking aspirin is some people with severe arthritis, like rheumatoid arthritis, might be taking aspirin in higher dosages. And that's a problem because when they take aspirin in these higher dosages, the reason why they're taking that aspirin is because they have inflammatory responses. Here's where it gets a little interesting. COX-1 has a smaller binding site than COX-2. COX-2 has a much bigger binding site. COX-2 is the enzyme implicated in inflammatory responses. Like someone who has chronic inflammatory issues, their COX-2 is reigning the day. When someone takes aspirin, the aspirin goes into these binding sites and joins, participates in acetylation, you don't need to worry about it, binds to the binding sites irreversibly. The problem with COX-2, when the aspirin goes into the binding site isn't completely plugged. There's still enough wiggle room for the COX-2 to actually process the arachidonic acid, and for COX-2, this is important for the inflammatory process. It's going to produce PGI2. And this is so that we get more blood migrating to wherever that inflammatory response is. We want more white blood cells to get there. So we learned earlier, if you take an aspirin, can you tell the aspirin exactly which COX to go to and where in your body? Nope. So because COX-2 is like the whore with a big binding site, we need to plug it up more. Which means, but you'll never forget that imagery, the person takes more and more aspirin to plug up and abate this inflammatory process, because living in chronic pain is no fun. But it also impacts COX-1. And we know COX-1 is important in the gastric epithelium. And that means the person taking these high dosages are also going to block their ability to make protective mucus in their GI or in their stomach, and this can lead to ulcer development. So pharmaceutical companies thought, aha, we're so clever. What we'll do is, because of these different sized binding sites, we will create a drug that can only fit into COX-2. It can't fit into COX-1. So they make this big drug that only fits in COX-2, but it's too big to go into COX-1. And that means the person can get relief from their chronic inflammation without getting ulcer development. So here's my narrow mouth versus wide mouth whore COX-2. When pharmaceutical companies developed these drugs that were specific COX-2 inhibitors, they didn't realize how good they were going to be. And what we saw was a disruption in the balance. Too much PGI2 was being produced. Or sorry, strike that, rephrase. When they took the COX-2 inhibitors, they blocked the inflammation. They blocked the PGI2. They blocked it. PGI2 is also important to repel platelets off of the endothelium. So if you block PGI2, prostacyclin, we tip the scale into thromboxane A2 getting too much control. And a lot of these people died because they formed clots. Some of these drugs are no longer on the market because they were too good at blocking the COX-2. Do not memorize this chart at all. Not at all. If you're wondering what IC50 means, it means inhibitory concentration at 50%. Meaning if you give this 50%, this dosage, you'll have inhibition of 50%. So you block 50% of the COX-2. So notice how good this drug was at such a low dose. It was blocking 50% of the COX-2. And that's why people were flipping over to the tendency to clot. It's kind of an interesting story. Do we, for testing purposes, discharge a patient on heparin?
No.
Okay. So you heard me say a few days before we discharge them, we want to transition them to Coumadin. Now, Coumadin was discovered because in the early 1900s, there was, do I have it on here?
And it's the next one.
Is it this one?
Yeah.
Sweet clotting, where is, yeah, early 1900s. About the same time as the Spanish flu was hitting. World War I, for any of you with history buffs. Who knew you would learn history and about cattle? But anyway, Coumadin was discovered because some cattle were grazing in the pasture, and the pasture, the grasses that were there started to ferment, and they were producing this coumadin, coumarin, warfarin substance. And the cattle kept eating it, and then next thing the farmer knew, a few days later, cows were dead on the pasture. So we started to analyze what was it in this fermenting grass, and could we use it to our benefit? So it turns out this ties into our vitamin K story. Clotting factors 2, 7, 9, and 10 are made in the liver, and they require vitamin K. They require vitamin K because these factors have tendencies to become oxidized. We'll stick with that. You know how iron, if it gets oxidized, you can't use it? If iron is oxidized in hemoglobin, it's methemoglobin, you can't carry oxygen. Okay, so these clotting factors also have a reduction oxidation story, okay? And vitamin K keeps them in a reduced state so that when they are released by the liver and do need to be converted from a zymogen to an active enzyme, they can be. But if they're not maintained in this state by vitamin K, we cannot activate them appropriately. So what will happen if we have patients with a vitamin K deficiency? Let's start with premature babies. Because they are born premature, they don't have a lot of vitamin K, right? They just got born. It needs to build up. What can we do to help don't I have preemies on here? We can give the preemies an injection. Liver failure patients, their liver is not storing enough vitamin K, can't make these clotting factors. Same story, if they need surgery, we can inject them with vitamin K, and we can have their liver somewhat functional within hours. Vitamin K, how do we get it? From our diet. We have to absorb it from our intestines. Problem. Vitamins A, D, E, and K are lipid soluble. And that means when you absorb them from your diet, you require bile to be released. Bile helps emulsify fats. And when you finally absorb the fats from your diet, these lipid soluble vitamins go with it. So if you are not producing bile, or you cannot release bile because you have an obstruction, you are not getting enough vitamin K from your GI tract, you might need a vitamin K injection. Who might have a bile duct obstruction?
Alcoholics.
Because of the ascites, right? We also learned how that can lead to problems with unconjugated and conjugated bilirubin if they don't have proper liver function. So we always come back to the alcoholics in these stories, don't we? So they are likely going to have a problem. But again, if you cannot make bile or release it appropriately, start looking for a vitamin K deficiency.
Would that be the same if you don't have a gallbladder to make bile?
Gallbladder, great question. Thank you. Anatomy was a prereq. The gallbladder does not make bile,
Yeah,
but it stores and concentrates bile. So a person with a gallbladder that's been removed, their liver is still making bile. It is still traveling through all those bile ducts, and it gets stored up because the hepatopancreatic ampulla stays closed until the bile needs to be released. So it's probably still enough for them to get vitamin K. Okay. But that's a great question.
And the person like gallstones, they might suffer from this too.
Well, if someone has really bad gallstones, we can try and shock them with sound waves to break them up,
Okay.
or we can remove the gallbladder.
So it probably wouldn't be like long term enough to have this.
No,
Okay.
because it's still the liver that's making the bile. Okay, so this Coumadin, the sweet clover disease that killed off some cattle in 1916, is a competitive inhibitor of vitamin K. So in the liver, coumadin, warfarin, goes to the liver and occupies vitamin K's binding site. So it's as if the liver doesn't have sufficient vitamin K. Well, then that means your factors 2, 7, 9, and 10 are going to be impacted. Of these 4 clotting factors, they are not made equally. They are part of a process. And when you have a vitamin K deficiency, the factor that is impacted of the 4 first, the first in line, is going to be factor 7. That's important for you to know because factor 7 is part of the extrinsic pathway. If a person is on heparin combining with antithrombin 3 blocks the intrinsic pathway. Do we discharge someone on heparin?
No.
Intrinsic pathway makes more PAS, correct? Extrinsic pathway, less PAS. So transitioning the patient off of heparin to coumarin, if they still need clotting therapy, is safer because the extrinsic pathway is not making as much PAS anyway. So it's a safer of the 3 pathways for us to go after. So again, vitamin K in the liver to keep those clotting factors in a usable form. Coumadin comes in, competes for vitamin K's receptor. It's as if your liver is experiencing a deficiency. You will have a problem keeping 2, 7, 9, and 10 in a usable form. But which one is impacted the most? 7. Okay, and 7 is part of which pathway? Good. Here's an issue though. If someone is on Coumadin and they change their diet drastically and they start eating a lot of green leafy vegetables, this is a good source of vitamin K. And now they're getting more vitamin K, and the vitamin K can compete back for its binding spots in the liver. And now factors 2, 7, 9, and 10 come back on board. And there's a reason why someone was on the Coumadin in the first place. They were on Coumadin to extend their clotting times, take longer to clot. If they start eating green leafy vegetables, the Coumadin is not as effective and their clotting times will decrease. That's not helping them. It's important, this story, because it's shocking to me how someone who's on Coumadin therapy is not really mindful of that. My next door neighbor, before he died, was on Coumadin. And right now in my garden, I have a lot of Swiss chard, kale, beets. Beets are a part of the family of Swiss chard, kale. And these are excellent sources of vitamin K. There gets to be a point where the children would say to me, no more, Mommy, no more Swiss chard, no more beets and beet greens that are grilled, because I use the whole plant. And I start giving it to the neighbors. Bok choy as well. I got heads of bok choy. I'll bring some in if you want some. Okay. Like, right now it's just the slugs trying to get in. So I gave some to my next door neighbor, and I kept bringing her some. She said, John and I just love these. We just love them. I didn't know he was on Coumadin. So one day I come over, and I'm bringing her a bag, and she says, no. John can't, the doctor said John can't eat your vegetables. And I went, why can't John eat my vegetables? And before she could even answer me, I said, is John by chance on Coumadin? And she went, yes. I said, how did the doctor exactly tell you that my vegetables are bad for John? And he was having home health nurses come and assess his clotting times. The extrinsic pathway was not where it should be. It was shortened up, not as long as it should be. So the home health nurse said, what are you guys eating? You need to go back to the doctor. He needs to get a new adjustment on this med. So Miss Tara, being Miss Tara, packs a grocery bag full of pretty much everything in the refrigerator, including my vegetables, to the doctor's appointment and shows him what they are eating, because that's what she does. And when she started pulling out my Swiss chard and my beets, the doctor went, that's it right there. How much of that have you been eating? That's what's making John's clotting times get out of the range I want them to be. So what did Tara hear? She heard Kara's vegetables are bad. So when I brought her more and she said, no, John can't eat your vegetables. I said, is he on Coumadin? Yes. I said, Tara, are you still buying these vegetables at the grocery store? Yes. I said, okay, we need to have a talk. It's not just that they're from my garden. It's these vegetables in general. And I can't really explain the science to her. I just said, it's all of these green leafy vegetables. It's not just from my garden. So you need to go back to just a lesser amount until his Coumadin levels are adjusted appropriately. Vitamin K, unlike heparin, does not work right away. It has to go to the liver. It has to compete for the receptors in the liver. It does not work right away. Heparin works right away. Vitamin K does not, which is why I said for the patient, we have to transition them before we discharge them. Yes? Okay. Yes, Hannah.
What kind of diet would be most fitting for patients on Coumadin?
They actually just say, don't switch your diet extremely. And because I had all those fresh vegetables, Tara and John were eating a lot more of them than normal.
What if they already eat a lot of them? Okay.
Right, so if they already eat these green leafy vegetables and they're not going to change, the doctor's probably going to give them a higher dosage. But it is definitely a drug that can be impacted by diet. Okay, so we have, I'm going to look at my slide, extrinsic and intrinsic. Intrinsic takes a little bit longer because we have more clotting factors involved in that cascade than the extrinsic. Again, Coumadin is going to compete with vitamin K and will impair 2, 7, 9, and 10, but which one is impaired first in the lineup? 7, which is why we can discharge a patient on Coumadin. It goes after 7 the most, and this will impair the extrinsic pathway, which does not lead to as much PAS, which means less tendency to clot. We want these patients to have a prolonged clotting time. Heparin is going to go after intrinsic pathway. When John was getting a home health nurse to come in and check his clotting pathways, there are 2 clinical tests we use to check extrinsic versus intrinsic. Extrinsic, we use the PT test, and intrinsic, we use the APTT test. We mix these chemical reagents from the kit, add blood, and we just basically assess how long it takes for the blood to clot in the tube. We used to do this as part of our blood lab, but turns out these kits are very expensive. The reagents are very expensive, and not in my budget. Not in my budget. Do not memorize the time for the APTT, nor PT tests. But you could see PT, faster. Extrinsic is faster. Fewer clotting factors involved. Intrinsic, longer. Seconds for both of them. We do these tests all the time in a clinical setting, especially before a patient is having surgery, because we want to see where they are on their clotting times for both intrinsic and extrinsic. We do the APT test to assess before surgery how much heparin we might need to give if they're going to be on a heart-lung bypass machine. We're also doing this test as we're adding the protamine, trying to reduce the times to clot. PT test, definitely very much used for the extrinsic pathway and Coumadin. I wish Kara was here because she probably would ask this question. Like, what is an INR, International Normalized Ratio? Don't memorize this. Let me summarize. These reagents get stored in the refrigerator. They can go bad. Things go bad in the refrigerator, like the antibodies I told you about. So depending on how old the reagent is, we adjust for the times in these tests. That's what an INR is. It's a way for laboratories all over the world to adjust for the freshness or not so much of their reagents for the PT test. That's all it means. I bet she would have had that question tonight. Okay, I asked you to keep track of things that would promote clotting versus not. So what doesn't promote clotting? The smoothness of the endothelial lining. We don't want the collagen fibers sticking out. Prostacyclin, PGI2, repelling the platelets away from there. Antithrombin 3 combined with heparin. Heparin is both endogenous and exogenous. Plasminogen, we could think of the clot buster, right? Sucking up those fibrin threads. There are many others that Guyton and Hall also talk about, but I'm not. So don't worry about thrombomodulin and protein C. Because if I get started on those, we would be here for another hour. And I don't think you want to. Why do we want to manipulate hemostasis? Well, because some people have a tendency to form a clot. And if a clot forms in a blood vessel, it is definitely going to obstruct blood flow. This is a clot. There's a big guy. An embolus is a traveling clot. Emboli is plural. A thrombus is a clot that's trapped in the blood vessel. Thrombi, plural. One of those words starts with T, and I think T for trapped. trapped blood clot. The other word, like emboli, you could rearrange the letters and it spells mobile. Traveling clot. The problem is, clots, when they form in the actual blood vessel, fragments of them can break off and start traveling to other places in the body. And they can get stuck in smaller blood vessels and obstruct flow in other places of the body, blood flow. You've heard of pulmonary emboli. Okay. Its name is actually misleading, if you ask me, because it sounds like it was a clot that's traveling through the pulmonary capillary beds. No. Its name means the clot started somewhere else. It traveled and got relodged in the pulmonary capillary beds, which are very small. And this is very, very life-threatening because now we're not getting proper oxygen gas exchange and CO2 gas exchange. So, what would we need to give a patient that is having a problem with these clots? Do we give them heparin to go after the clots? Heparin does nothing to current clots. So we would need to give the TPA, urokinase, or streptokinase. Remember, they're the ones that can activate plasminogen into plasmin. But a lot of times, students want to say, oh, we give them heparin. Heparin does nothing for a current clot. Heparin will prevent future clots, but it does nothing for a current clot. I said I would tell you about an extreme case where someone might be discharged with heparin, low molecular weight heparin. This is antiphospholipid syndrome. Antiphospholipid syndrome occurs like this. Here is platelet factor 3. You heard me say it came from platelet cell membranes. It has a carrier. Because it's a phospholipid, this thing that's in the cell membrane, it's not very water friendly. So here's a carrier that makes this more water friendly. As long as platelet factor 3 is tethered to this carrier, it will not launch the intrinsic pathway. Some people have this disorder where they make antibodies. It's an autoimmune disorder. The antibodies go after the carrier and dislodge it from platelet factor 3. When platelet factor 3 is on its own and out of the platelet membrane, it's going to launch the intrinsic pathway, which means clotting times will reduce. This person definitely will warrant heparin therapy to increase the clotting times, to block the intrinsic pathway. I actually had a woman in my class that had this syndrome, and she knew it, and she wanted to have a child. She got pregnant, and they had to definitely monitor her being on the heparin because they didn't want her to clot because that could obstruct the blood flow to her uterus, and that would obstruct gas exchange for her fetus. But they couldn't give her too much because then she could bleed out through the placenta, right? So I can't believe she actually had a successful pregnancy, but she did.
I work at a high-risk pregnancy practice, and it's really common for us to have patients who are on heparin. In our practice.
Okay, so say again what your practice is.
High-risk pregnancy practice.
Okay.
So you're there, yeah, exactly, for that.
So these extreme cases all go there, which is why you said we have
antiphospholipid, yeah.
a lot of patients, which made half the class who's tired right now going, oh, Kira said there was just extreme cases. Why do they have so much of it?
Yeah,
They took the extreme cases, move over here.
Yeah.
Thrombocytopenia a reduced platelet count. If you have a reduced platelet count, you're more likely to have bleeding through the little micro tears that I told you we all have in our bodies right now. And the blood could actually seep out of the blood vessels and accumulate underneath the dermis. And this makes it look like you've got little red dots all over you. Those are called petechiae. And they can get bigger, like the size of a nickel, and then we call them purpura. A person can develop thrombocytopenia because they might have an autoimmune disorder. They might have been exposed to some sort of drug that they reacted adversely to. They might have been sick. My son Hayden woke up one day and he had petechiae all over the inside of his thighs. He said, "Mom, I have this rash." And I said, "Well, does it itch? Can I touch it?" It wasn't raised. It was very smooth. I went through my checklist. Didn't change laundry detergent. I said, "H, when you went to your soccer practice, did you wear your running shorts underneath? Because, you know, you can chafe. The inner thighs can rub." "Yeah, Mom, I did." So I took him to the doctor because I ruled all the usual suspects out. Took him to the doctor. Doctor drew blood. That was appropriate. Said, "Streak, come out here. I think I know what this is." And I looked at it and I thought, yep, that was my guess, thrombocytopenia. And he said, "So this is caused by bone marrow failure." That is what he told me, which was not a false statement, but that is all he told me. And I said, and he said, "And what?" I said, "But it's also caused by other things as well. And you should probably start telling me these other things, because if I were not an educated person, I'd start thinking that my kid needs a bone marrow transplant." "Well, I can draw more blood and send it out to an outside lab for further analysis." And I went, "Yes, this is what we do." Because what you should have said was, it could be caused by bone marrow failure, but probably you should start with something less extreme. Hayden had been sick for weeks, and more blood work showed that he had mono. And mono went after his platelets. So there was no reason for me to start looking for a bone marrow donor. This self-resolved, in many cases self-resolve. His did. There was no real big issue except for where are platelets removed from the bloodstream, liver and spleen. And his spleen was enlarged, and he had to stop playing soccer for about 6 to 8 weeks because the doctor was afraid, because it's a contact sport, it could rupture his spleen. And if we can't figure out what's the cause, we can remove the spleen and reduce one of the places that we're removing the platelets from. Hemophilia is another blood disorder. There is hemophilia A, known as classic, and hemophilia B. Hemophilia B is not referred to as non-classic, just so we're clear. Now be careful, be very careful. I am talking about clotting factors 8 and 9. Okay, 8 and 9. 8 is classic. 9 is hemophilia B. The reason why I'm telling you to be careful is both of the genes that code for these clotting factors, because they are proteins, the genes are on chromosome X. So I don't want you to confuse all the Roman numerals that appear on this slide. Clotting factors 8, clotting factor 9, their genes are found on chromosome X, which is one of the sex chromosomes. Men have one X chromosome and one Y chromosome, and women have 2 X chromosomes, which makes the genetics for hemophilia pretty unique. We say it's sex-linked. It's kind of interesting. We can actually see some royal families have a generation-to-generation history of hemophilia running in their family. Why is that? Why did it impact the royal family so much, you might be thinking? Because back in the day, royals thought they had royal blood and they needed to keep it in the family. So there were a lot of incestuous marriages, shall we say? Do you really need to write all this down? What do they have a problem with? Bleeding. Even a child losing their baby teeth can lead to a life-threatening situation. Lots of nosebleeds. They even bleed into the joints, so there's joint pain. And if you read some of the literature on some of the late princes from a long time ago, you might be reading about some of these budding young kings, and you might be reading like, what a wuss. A king is supposed to defend his country, his kingdom. And a lot of these wanting to be, soon to be kings were isolated in the castle. It seemed like they didn't go out, they didn't do any swordplay, probably because they had this genetic disorder, and any kind of roughhousing play could lead to bleeding. So there you go. Some more history. The XX chromosome, females, XY, males. The Y chromosome is actually, I don't mean this to be insulting, but in genetics speak, we refer to the Y chromosome as the mutant chromosome. It is a genetic wasteland. Wasteland. There aren't a lot of genes on that chromosome. There's a lot on the X. So the women are like, yep. But there is an important gene on the Y chromosome, just so you know. It's called the SRY gene. And that is the gene required for testicular development. There are some individuals that have an XY chromosome. The Y chromosome has a mutation in this SRY gene, and the default is to develop as a female. That's just kind of a fun side fact. I like to think that the SRY gene stands for sorry, I'm going to grow testes. That's my. But I mean, I did tell you my joke, right? About you do know which sex can actually sleep on their sides better? It's men. Because they have a kickstand. Feel free to use that one. It's a good one, never gets old. Okay, so if a male gets a mutation in the X chromosome in the area that codes for either factor 8 or factor 9, they have no backup, and they're going to have hemophilia. If a female has one of her X chromosomes mutated in those genes, she's got a backup. She will be a carrier, but she will not necessarily have hemophilia. She would need to have both of her X chromosomes mutated. So here we have a dad that has hemophilia. Let's say he lives long enough to mate. Mom is fine and normal. He is going to either throw an X chromosome. If he throws the X chromosome, it's going to be a girl. It is the dad that determines the sex, King Henry. If he throws the Y chromosome, he's going to have a son. So in this scenario, his sons will be fine. His daughters will be carriers. Right? That's all they can be. If we have a normal dad, but we have a mother who's a carrier, so let's take one of these daughters, and she procreates, we're going to see that 50% of her daughters are carriers and 50% of her sons are going to have hemophilia. The dad can only throw the healthy X because he was normal and healthy. The mom throws one of her two X's, either the damaged mutated one or the normal one. I think this is the last slide. That doesn't mean we're done. It can be, but I don't think you want to. Anyway, this is disseminated intravascular coagulation, or DIC. DIC was that issue where I said some people start bleeding so much from injuries that they have that they consume all of their clotting factors and then they end up bleeding out. This can happen in crushing injuries, car accidents, helicopters crashing into a hillside. Too soon? That one was actually blunt force trauma, but I just thought I'd throw that in there. Stab wounds, bullet wounds, anything that is consuming massive amounts of clotting factors, and then you just don't have enough to plug all the tears. A sidekick of DIC is something called HELP, and it stands for hemolysis, elevated liver enzymes, low platelet count. We see this in some moms that get pregnant. It is when a mom births that child, there's a lot of bleeding. There's a lot of bleeding. And we need the bleeding to stop, and that's part of the reason why. How many of you haven't had children yet? Okay. So when you watch TV shows, reality TV shows of moms that are pregnant, like Baby Story, and you're going to the hospital with them to watch the birthing process, and isn't it wonderful and beautiful and amazing? And it's amazing that their hair is done and their makeup is done and they just look like princesses. And then what they don't show you in those TV shows is that after you birth that parasite, you have to birth the placenta. They don't show you that part. They don't really tell you about that part in your birthing classes either. I'm going to tell you about it right now.
Why did you take it off?
Because it was bothering my neck. It was dramatic. It was like Horatio that always takes off his glasses on CSI Miami. Here takes off her badge. It's her signature move. When she does that, it's on the test. It's not. It was just bothering my neck. But thank you. I'm going to turn that into my signature move now. So you birth that parasite. Nurses swoop it away to the cute little incubator, and they start assessing APGAR scores like how can your baby cry and is it breathing right. So then people are over here taking pictures. Meanwhile, you're still over here with someone between your legs. And you're like, no, you're not done. Then you feel this thing come out of you that is just a crazy sensation. I will describe it. And everyone's enjoying the baby. Meanwhile, nurse and doctor come over and they turn into wrestlers. And it's like smackdown. They're pushing on you so hard. They're trying to get your uterus to collapse, basically, the myogenic mechanism to reduce the blood. And so they push on you, and it's actually very uncomfortable. Huh?
I always thought that just happened naturally.
No, they push. It is not, and they push hard. So then they do this, and you're like, why? And then they explain it to you. Then they let you rest for a while. You think you're done. Nope, you're still bleeding inside. So they go over and play with the baby and work on the baby, and then they come back and they start pushing on you again. Meanwhile, you've got blood that is starting to coagulate inside you, and as they push, it comes shooting out. You are a human toothpaste tube of coagulated blood. Stay on the north end, dads, if you don't want to see that part. It is not as miraculous as your baby turning your wife's labia into Broadway curtains because they go wide. But you can maybe understand that because the baby's head's coming through Broadway curtains. That part with the coagulated blood, not so glamorous and a little upsetting. Oh, yes. When I birthed my first child, I went into labor the night before. The next day didn't go in to the hospital because I was tutoring a student who was in dental school and could not read nor write. Figure that one out. That's a totally different conversation. Just tutoring them in anatomy. You could just use pictures. Just saying, do you want that person as your dentist? How do they know which drug to give you? Anyway, so I didn't go into the hospital until almost 24 hours after my water broke. The nurses and doctors were not happy with me because that can invite bacterial infections. Boy, did I pay for that. So by the time Hayden was born, it was 1:57 p.m. the next day. And I remember that because the doctor kept screaming at me saying, I want this baby born by 2 o'clock. Okay. So he's screaming at me, and I'm so drugged up because the nurse the night before got annoyed with me because I'm sitting in bed going, when are we doing this? When do we go? When do we go? She's like, honey, you got along. You need to sleep. I'm going to give you something to sleep. And the next day, I was just, they're telling me to push. Honey's grabbing my head and turning me into this like half moon. And you got to push because the doctor's yelling at us. Anyway, finally get Hayden born. Placenta out, human toothpaste tube. Honey comes over, loving, what can I get you? Can I get you anything? Like, push present. You've heard of that, right? What do I ask for? A pizza. That was my push present. Go higher, ladies. But I was so hungry. So the nurses are hilarious. The nurse says to my husband, oh, there's a pizza place right across from the medical center. We order from them all the time. They know where to deliver to our floor. So Honey gets the number, calls for the pizza. Delivery boy comes to deliver the pizza. Nurses at the nurse station direct him to the room I'm in. With blue diapers and even buckets full of afterbirth. That poor boy, scarred for life. The nurses thought that was hilarious to do that to him. I thought that was very cruel. Very cruel. He went white. And I'm like, honey, you need to tip him a lot. Anyway, I got my push present pizza. So, this is a complication, one of the most common complications of childbirth. Lots of bleeding. Woman can't clot enough because of the torn placenta. It rips out of you. And that's why the doctors and nurses are on you so hard trying to get the uterus to contract and reduce the amount of blood flow. Some women have low platelet counts. It is now standard for doctors to screen for help. Let me say that again. Screen. And for help, it just doesn't get old. And they can determine if they should have some platelets on hand in the delivery room if that woman should end up having a problem. Good.
Are you really supposed to eat the placenta?
Oh my God. No. Never having children. Never happening.
Some women get it freeze dried and they're popping the pill. But they do not get your placenta and serve it to you with cutlery. Do animals do that? Yes, animals do that, mostly to hide the scent of the newborn from predators.
There's some cultures that do.
I know, but there really is not.
Not a whole lot.
They're thinking of the iron, replacement of the iron. I get that, I understand that, but we have these things called iron supplements now. Yes, Hannah.
For a C-section, is there anything special they have to do to take the placenta out? No. Do they just?
They just rip that out too.
Because if it's attached to the uterus, do they just?
It just comes off. It's like a bowl. It's a bowl-shaped organ, and eventually with the uterine contractions, the whole thing gets ripped off of the uterus.
Yeah, they pull it out, and then as soon as baby comes out, even before they pull out the placenta, we start giving the oxytocin to do the uterine contraction.
The oxytocin is another way to get profound uterine contractions. That's what causes uterine contractions during labor. Yes.
During like a C-section, do they just take it out, or do they?
Yeah, that's what Hannah just said. No, it's okay. Yeah, that all needs to come out. Otherwise, if it stays in there, it'll get necrotic, and that can lead to an infection and death. Yes, and death. Okay, would you like me to tell you anything about your exam?
Yes.
That's why I said last slide, but you probably don't want me to be finished.